In this lecture, I'll be covering disorders of sodium. Here are the learning objectives. It is very important to remember that a sodium problem is actually a water problem. Remember, sodium does not cross the semipermeable membrane freely. It creates an osmotic gradient that pulls water towards it, whereas water does cross freely. So if the serum sodium is decreased, then the total body water will increase. And if the serum sodium increases, then the total body water will decrease. So a sodium problem equals a water problem. So what controls sodium? Basically, increased plasma osmolality causes secretion of ADH or vasopressin, which decreases plasma osmolality. Or decreased blood volume, such as hypotension, causes thirst, which increases fluid intake, which increases arterial circulating volume. So basically, our bodies are very smart at fixing its problem. Here's another diagram explaining it, but basically hyperosmolality or decreased arterial receptor firing or angiotensin II or sympathetic stimulation stimulates the hypothalamus, which stimulates the posterior pituitary to secrete ADH. This further acts on blood vessels and the kidney. It increases systemic vascular resistance and increased blood volume, which increases arterial pressure. ADH, or antidiuretic hormone, otherwise known as vasopressin, I often remember from the mnemonic adds hydration. Its maximum effect, so if you're secreting ADH nonstop, your max urine output per day would only be about 500 mLs per day. This is why you typically get a dry mouth when you've had a night on the town. However, if you don't have any ADH in your body, you are going to pee out approximately 15 to 20 liters per day. So you can see how important this hormone is. Now we'll discuss hyponatremia. As far as the prevalence of hyponatremia, it affects 27% of patients admitted with heart failure, 50% of patients with cirrhosis and ascites, 13% in endurance athletes, and 30% of patients on thiazides for greater than 10 years. It's also present in patients taking SSRIs and SNRIs within 2 weeks. So my point with this is you're going to see it a lot, so I feel like it's really important for you to understand, even though it is one of the more difficult subjects in medicine. Here are a list of the common symptoms you'll see with hyponatremia. So let me ask you, do symptoms actually matter in hyponatremia? Well, let me tell you, they absolutely do, because it basically tells you how aggressive you need to be in your treatment approach. However, you should never wait until a patient is symptomatic before you treat it. The keys to working up hyponatremia include, obviously, you would need a serum sodium level. You would also need a serum and or calculated osmolality. Remember the formula from the previous lecture on how to calculate the osmolality. And then you also have to have an accurate assessment of volume status. So you can't just determine the underlying cause of hyponatremia based off labs alone. You have to actually have a patient to look at. You'll also need a urine sodium, which can be used to calculate a FeNA, or fractionated excretion of sodium. Now, this can be a little bit confusing because you probably learned the FeNA calculation in acute kidney injury. However, it can also be used in hyponatremia. Remember, FeNA is basically the serum sodium divided by the urine sodium. So if this is greater than 1 in a hyponatremic patient, that means the kidneys are not working. So the kidneys are releasing sodium despite being hyponatremic in the serum. Whereas if the FeNA is less than 1, the kidneys are working correctly. So the kidneys are trying to reabsorb sodium as much as possible. Next, you'll need a urine osmolality, which I'll discuss later. And finally, you just have to use your brain, you have to use the algorithm, and you have to think through the process to truly come up with the underlying cause. Now I'll run through the hyponatremia algorithm. I would highly advise that you keep this in your peripheral brain while on rotation and refer back to it as often as you need. However, if you memorize this algorithm, then you will never miss a hyponatremia question on your boards or tests in the future. The first step is to determine that the patient is hyponatremic, that being a serum sodium level less than 135. After this, you'll decide whether they're symptomatic or asymptomatic. Obviously, if they're symptomatic, you need to be more aggressive in your treatment. Step is to determine the serum osmolality. This can either be calculated using the previous lecture formula, or it can be sent to the lab and calculated by them. If the serum osmolality is normal, it's called isotonic hyponatremia. If it's low, it's hypotonic hyponatremia, and if it's high, it is hypertonic hyponatremia. If they have isotonic hyponatremia, it basically means that the serum osmolality is normal, but another osmol is interfering with the osmometer, such as proteins or triglycerides. This is why it's called pseudo-hyponatremia. This is more of a historical finding, as new osmometers don't get interference from these osmoles. If the osmolality is high, it means another effective osmol is causing the hypertonia, such as glucose, mannitol, sorbitol, or radiocontrast dye. Glucose is the number one cause. Glucose excess causes water to shift from the cell to the extracellular space, which causes hyponatremia. Hyperglycemia, remember, is the number one cause of hypertonic hyponatremia. The correction for this is very, very important in diabetic ketoacidosis, but it's basically 1.6 for every 100. So if a patient's blood sugar is 200, you would increase the sodium by 1.6 to get the corrected sodium. If the serum osmolality is low, this is what we refer to as true hyponatremia, and this is what the hyponatremia workup is really all about. It basically causes cerebral edema, so it's necessary to diagnose this as quickly as possible. The next step in treatment is to determine what the patient's fluid status is. Are they hypovolemic, are they euvolemic, or are they hypervolemic? So to determine that, you need to really know their history. Have they had any nausea, vomiting, diarrhea? Are they dehydrated? Are they malnourished, such as hypovolemia? Are they hypervolemic, such as heart failure, cirrhosis, or renal disease? Are they euvolemic, such as what you'll see in SIADH, or thyroid disease, or polydipsia? This is when you'll go to the next step. If you determine that the patient is hypovolemic, which means they appear dehydrated, the next step is to assess the urinary sodium. If the urinary sodium is greater than 20, which correlates to a FeNA greater than 1%, this means the kidneys aren't functioning normally, because in a hyponatremic state, the kidneys should be reabsorbing as much sodium as possible. Think of a patient on diuretics or mineralocorticoid deficiency. Remember, diuretics, typically thiazides greater than loops, cause the hyponatremia. Whereas if the urine sodium is less than 20, this correlates to a FeNA less than 1%. This means the kidneys are working correctly by trying to reabsorb as much sodium as possible. Think of extrarenal losses like vomiting, diarrhea, third spacing, or bowel obstruction, in which the treatment is to replace the losses of the is to replace the losses with isotonic fluids. So why would you treat with isotonic fluid? Because remember, they're actually hypertonic to the patient's serum, which is hypotonic. If the patient has euvolemic hypotonic hyponatremia, these patients usually have a high urine sodium because something else is causing the body to hang on to as much water as possible. The next step is to determine the urine osmolality, which is basically to determine if the urine is concentrated with osmoles or not. If the urine osmolality is high or greater than 100, this indicates the patient likely has SIADH, hypothyroidism, adrenal insufficiency, stress such as surgery or sepsis, or drug abuse. Now in SIADH, the patient is secreting too much ADH, which means they are absorbing as much water as possible. This makes their urine more concentrated. When you're thinking of hypothyroidism, you need to think myxedema, which basically causes decreased cardiac output and GFR. Adrenal insufficiency, think Addison's disease. Now, if the urine osmolality is less than 100, this means that the urine is diluted out. Conditions for this include primary polydipsia, in which the patient drinks too much water, such as in psychogenic polydipsia, or beer potomania, where patients drink a ton of cheap beer and are getting too much solvent when compared to solute. It can also happen as exercise-induced, so think of marathon runners that consume too much low solute drinks while sweating like crazy. As a side note, there was a competition several years ago on the radio called Wee for Holding Your Wee, in which you had to drink a gallon of water and see who could hold their urine the longest, and the winner would get a Wii, the PlayStation type game. So during this competition, a girl actually died from hyponatremia, and the family got like $2 million in the lawsuit from that. The third type is when the urine osmolality is variable, or goes up and then down, and this is called reset osmostat. This occurs when the brain resets itself to a normal sodium level and is treated with fluid restriction. And you'll see from all three of these, they're all three treated with fluid restriction. Now in hypervolemic hypotonic hyponatremia, this is usually the easier type to determine because the patient will have signs and symptoms of volume overload. If the patient is volume overloaded, you need to look at the urine sodium to determine if the cause is before the kidney or if it's after the kidney. If the urine sodium is less than 20, otherwise a FeNA less than 1%, that means the kidneys are working, but patient is volume overloaded, such as in heart failure and cirrhosis. This is treated with diuretics and fluid and salt restriction. If the urine sodium is greater than 20, indicating a FeNA greater than 1%, that means the kidneys are not reabsorbing sodium and therefore failing. This is treated with fluid and salt restriction and, if necessary, hemodialysis. Now, if the patient has severe hyponatremia, which is defined as a serum sodium less than 125, and with symptoms, usually altered mental status and seizures, this is when you need to correct the sodium quickly. This involves treatment with 3% saline, which can be either calculated based on the patient's body weight or as boluses with frequent sodium checks until the symptoms resolve. Once the symptoms have improved and the sodium has improved roughly around 6 milliequivalents, you can usually go back to the other algorithm and work your way through it. Now, I just wanted to discuss a little bit more about SIADH because it's very important and you'll probably see it on your rotations, especially your inpatient rotation. It is the most common cause of hyponatremia and affects approximately 10% of hospitalized patients. It's due to an ectopic production or increased release of ADH from the pituitary gland. Specific causes, honestly, almost anything can cause SIADH. Malignancy, pulmonary disease, CNS disorders, infection, so remember sepsis, pneumonia, UTIs, all that. Medications, SSRIs and tricyclics. Also chemotherapy can cause it. There are basically 5 different types of SIADH, but I'm not going to cover this, and I wouldn't expect you to memorize this. Honestly, this is if you did a nephrology rotation, they would probably try to get you to learn some more about this. The treatment of SIADH, the number one treatment is to treat the underlying cause. So if they're septic, you have to treat the sepsis. If they have underlying CNS disorder, you have to treat the CNS disorder, and usually the SIADH or the hyponatremia will slowly resolve. Also, you need to fluid restrict these patients. That's why it's so important A lot of times in the ER, you'll see that, doctors or PAs or whoever, they'll just automatically see a hyponatremic patient and just give them fluids thinking that it's due to hypovolemia. However, if they have SIADH and you give them fluids, you are going to drop their sodium even more. That's why it's imperative to determine the cause of hyponatremia before you actually treat it. So the fluid restriction is typically under 1 liter per day that you need to put them on. This is not going to be well tolerated for them, but it's necessary until their sodium improves. The final treatment of SIADH is those Vaptans, which I'll talk about later. These are usually ordered by nephrology as they can be very dangerous. So the medical director at my PA school was a nephrologist, and he told me this, and I just want to pass it on to you just so that you know. Anytime you see a question where a sodium is less than 120, it's got to be SIADH. I pretty much guarantee that's what the answer that they're going after. Now let's go through some examples of hyponatremia workup so that you can get a feel for the breakdown. So let's say you have a 57-year-old white female admitted for confusion, lethargy, and falls. Patient appears euvolemic. Her vitals are stable. Chest x-ray reveals right lower lobe pneumonia. Initial labs from ED reveal WBC of 15, hemoglobin of 12, sodium of 122, glucose of 120, BUN of 12, creatinine of 0.90, serum osmolality of 260, urine osmolality of 200, and a urine sodium of 114. So what type of hyponatremia does this patient have? From all of those details, you should be able to figure this out. So you can pause it here if you need a couple minutes to look at it or review it. But basically, this patient has hypotonic, euvolemic hyponatremia. So what's the most likely cause of that? SIADH, right? So is any other testing warranted? So for this patient, even though you suspect that it's SIADH, likely from the pneumonia, sepsis, whatever the patient has, you still should probably rule out underlying myxedema. Addisons and stuff are a little less common, but you'd at least want to get a TSH with free T4 and possibly a cortisol level. So how would you treat this patient? Remember from the previous slide, how would you probably treat this patient? Treat the underlying condition. So you treat the pneumonia and the sodium will probably get better. You'll also want to fluid restrict the patient, and you would consider adding a Vaptan if the patient's condition didn't improve. But this would be where you would get a nephrologist to probably help you out. Here's another example. So let's say you have a 65-year-old male presents to the ED with dyspnea on exertion, chest x-ray reveals mild pulmonary edema, exam reveals crackles in lung bases, 3 plus lower extremity edema, and an S3. So clearly this patient's likely in heart failure. Labs reveal white count of 11, hemoglobin 9.5, sodium of 127, so that's definitely low, but not in the critical category, but you'd want to assess for symptoms. The glucose is 150, just mildly high. BUN's 20, creatinine's 1.4. It was 0.87 though 3 weeks ago, so this patient technically has acute kidney injury according to KDIGO criteria. The bicarb is 32. So here you can look at the vitals. Blood pressure's definitely elevated. Heart rate's upper end of normal. Pulse ox is low. Definitely this patient needs to be put on oxygen. And you can see that their weight has increased quite a bit over the last 3 weeks. So it's pretty easy to tell what's going on with this patient. So they more than likely have heart failure exacerbation. So what type of hyponatremia does this patient have? So if you go through that formula, remember to calculate osmolality and tonicity, you could actually figure out that this patient actually has hypotonia. Okay, and then you know from the exam that they have hypervolemia. So what further testing do you need to work up this patient? Do you really need any other testing? Really, I mean, you know what the cause is, so you should know how to treat it, right? You're going to fluid restrict the patient for their heart failure. You're going to put them on a 2 to 3 gram sodium restriction, and you're going to give them loop diuretics. So as far as hyponatremia treatment goes, you first have to determine whether the patient has acute or chronic hyponatremia. Acute hyponatremia is less than 48 hours, whereas chronic is greater than 48 hours. If you can't determine acute or chronic, just assume that it's chronic. However, if they have acute symptoms, then you need to worry a little more and be a little more aggressive. Remember, acute hyponatremia typically means the brain hasn't been affected yet, so it takes a few days for the hyponatremia to actually hit the brain. So this is why osmotic demyelinating syndrome is not as much of a worry in acute hyponatremia. It's okay to correct it quickly, whereas in chronic hyponatremia, the brain has already been affected, so ODS is much more concerning, so you need to correct it very, very slowly. So just to reiterate, chronic asymptomatic hyponatremia, urgent treatment really is unnecessary. Your aim is to prevent osmotic demyelinating syndrome. You also want to treat the underlying cause with a goal of 6 millimoles per liter per day and never over 10. And just to review treatment of specific causes of hyponatremia, if it's diuretic induced, you obviously stop the diuretic and correct the volume deficit. If it's SIADH, remember, treat the underlying cause, fluid restriction, and consider Vaptans. If it's mineralocorticoid deficiency, you correct the volume and you add fludrocortisone. If it's glucocorticoid deficiency, you give maintenance or stress dose steroids. And if it's severe hypothyroidism, usually you need to give them IV thyroid hormone replacement. If they have heart failure, you're going to give them fluid restriction and you're going to give them loop diuretics. If the sodium doesn't correct to the desired level, you ease the fluid restriction and consider starting a Vaptan. If they have cirrhosis, you need to fluid restrict them, and Vaptans only if the benefit outweighs the risk, as this can worsen their liver function tests. So this is usually given by a nephrologist. In chronic kidney disease with hyponatremia, you need to fluid restrict them. Vaptans really don't help much in this situation if the creatinine is greater than 2.5. Now for SIADH, I already discussed the treatment. Remember, treat the underlying cause, fluid restriction. However, I also just wanted to take a brief minute to discuss the medications. First, the vasopressin receptor antagonists, or VRAs, primarily the Vaptans. They work by inhibiting the action of ADH on its receptors, so it basically blocks ADH, which causes aquaresis, causes you to pee out everything, which is going to increase your sodium. Conivaptan is the primary IV Vaptan, whereas tolvaptan is oral. Demeclacycline is a tetracycline antibiotic, and it's an indirect antagonist. It's not as effective as the Vaptans. And lithium also not as effective, but it's, similar to demeclacycline. Honestly, I don't ever see those used. The newer Vaptans work by far the best. Now I'll talk briefly about osmotic demyelinating syndrome, formerly called central pontine myelinolysis. The number one cause is basically us, when chronic hyponatremia is corrected too quickly. ODS is basically when fluid is driven into the neuron, causing them to swell and break down. It typically presents in a biphasic pattern. Typically, patients improve neurologically, then over several days, they develop new, progressive, and sometimes permanent neurologic deficits. They typically present with para or quadriparesis, dysphagia, or locked-in syndrome or other neurologic deficits. The affected area include usually the pons greater than the cerebellum, greater than the lateral geniculate body, greater than the thalamus, and then the putamen and cerebral cortex. Obviously, I don't want you to remember this, but with the pons, the old mnemonic CPM, that would affect speech and swallowing, so they will usually have dysarthria and dysphagia if this area is affected. The cerebellum obviously causes falls and ataxia and discoordination. The lateral geniculate body, this is the relay center in the thalamus for the visual pathway, so the vision is usually affected. The thalamus controls consciousness, sleep, alertness, that kind of stuff. And then if the putamen's affected, it usually regulates movements at various stages like preparation and execution, and influences various types of learning. So the diagnosis is mainly clinical, as it can take 2 weeks or more to show up on actual imaging. The treatment of ODS is you have to stop correcting the sodium first. Then you consider high-dose steroids such as Decadron, and then you've got to re-lower the sodium. Remember when I talked about that in IV fluids, if you needed to re-correct, that can usually be done with desmopressin, which causes fluid retention, or increased fluid intake, or with D5. And then you need to monitor the sodium hourly when this condition is suspected. Now I'll discuss hypernatremia, but it's important to note that this is much easier to understand than hyponatremia. Now, hypernatremia has 3 common causes. First is dehydration, and this is the primary cause of hypernatremia. Other is hypertonic fluid, which is rare. And then the last is defects in the ADH, which is also diabetes insipidus, which is also extremely rare. For dehydration, usually you'll see a urine osmolality very high, usually over 600, and the treatment is to replace the fluid deficit. Now, if hypertonic fluids is the cause, it's usually us. We've given the patient too much fluid. However, another cause is excess salt intake. For instance, parents that are abusing their children by making them eat, excessive salt as a punishment. I've personally seen in the ER. Other people just excessively love salt. I know my daughter loves salt, but we constantly have to take it away from her. And then finally is defects in ADH. So this is where you get polyuria plus hypernatremia. Diabetes insipidus, basically there's 2 different causes. There's central and there's nephrogenic. Central is when ADH is not being secreted from the brain. The treatment is just to replace the ADH. This is usually done with intranasal or oral desmopressin. However, nephrogenic diabetes insipidus is where the ADH is not working in the nephron. The treatment for this is actually much more difficult and usually done by a nephrologist, but it includes decreased solute intake and thiazides. You usually have to do a desmopressin challenge test to differentiate which type it is. As for the treatment of hypernatremia, it's actually pretty simple and very similar to hyponatremia. Number 1, you have to treat the underlying cause, so you have to figure that out, and usually, like I said, it's dehydration, so it's pretty simple to figure out what the treatment should be. Remember, when correcting, it's just like in hyponatremia. You should never do more than 10 milliequivalents per liter in 24 hours. Overcorrection will actually cause the opposite of hyponatremia, so you would get cerebral edema. I know these are very difficult topics to understand, so if you have any questions, please feel free to post any questions you have on the Google document. Here are the sources I had for this lecture.